Good morning, good evening, wherever you are in the world. We are so honored to have all of you here today for this first virtual global grand rounds of the American Academy of Otolaryngology Head and Neck Surgery Foundation for the 2023 calendar year. We have an all-star international lineup on endoscopic sinus surgery, which we will get to in just a couple of minutes. First, I wanted to introduce myself as the coordinator for international affairs for the American Academy of Otolaryngology Head and Neck Surgery, and to introduce our president of the American Academy of Otolaryngology, Dr. Kathy Uremchuk, who we are honored to have here today to give a few words to our audience.
Thank you, Mark. I really do want to welcome everyone to the International Advisory Board's virtual endoscopic sinus surgery session. The American Academy of Otolaryngology is excited and honored to convene this virtual meeting. As president of the American Academy of Otolaryngology, it is amazing to see the global community come together to learn and improve patient care. I hope you all enjoy this session today, and I look forward to further ones in the future. Thank you.
Thank you so much, Dr. Uremchuk. We're also so honored to have with us today our Executive Vice President and CEO of the American Academy of Otolaryngology Head and Neck Surgery, Dr. Jim Denaney.
Thank you, Mark. Again, I welcome all of you here today. Thank all the people that want to put this together, our international committees, our staff, and particularly our speakers today. I'd also like to add in our great heartfelt concern for those in the Mideast, in Syria and Turkey, who had an earthquake several weeks ago, and we wish our best wishes and quick recovery for you. Thank you again for attending.
Thank you so much, Dr. Denaney. We have over 2,200 attendees registered for this global grand rounds. We have over 126 countries representative, and we really look forward to this global grand rounds. This global grand rounds is a particular collaboration with the Pan American Association of Otorhinolaryngology, and we are so honored to have an international leader in global otorhinolaryngology with us today, Dr. Jacqueline Alvarado, who is the General Secretary of the Pan American Association of Otorhinolaryngology.
Thank you, Dr. Sasferio, for your leadership in the American Academy in the Academy International Program, and for organizing the series of the 2023 Global Grand Round. On behalf of the Pan American Association, we value the collaboration between our society and the American Academy of Otolaryngology. We'd like to thank Dr. Denaney and Dr. Uremchuk for their support and partnership. The Pan American Association of Otolaryngology and Head and Neck Surgery is honored to participate in this joint virtual grand round organized by the American Academy of Otolaryngology. The synergistic work between societies through joint meetings like the recent Pan American Congress in Orlando enhance the scope of the most important mission, which is education. We congratulate Dr. Sarah Weiss and Dr. Pavol for organizing a high-quality panel with inclusion and diversity. We'd like to thank Elise Swinhart and Katie Graham-Stoff for their dedication and excellent work with the international community. We'd like to invite all of you for our next Pan American meeting in Buenos Aires, Argentina, June 25-27, another joint meeting with the Academy to continue working together in strengthening our specialty. Thank you.
Thank you so much, Dr. Alvarado, and thank you so much to the Pan American Association of Otorhinolaryngology for being such a great partner with the American Academy. So without further ado, we'll move right to our panel today. We will introduce Dr. Pavol, who needs no introduction. He has been a long-term leader of global otorhinolaryngology, including a longtime board member of the American Academy of Otolaryngology Head and Neck Surgery. He is a professor at Emory University, and he will co-moderate our panel today with Dr. Sarah Weiss. Dr. Stolowitsky.
Thank you, Dr. Sasferio. It is my distinct pleasure and honor to introduce my colleague and friend, Professor Sarah Weiss, who will moderate this year's Rhinology Global Grand Rounds on endoscopic sinus surgery. She assembled an outstanding faculty from different corners of the world to discuss techniques and strategies to optimize patients' outcomes. Dr. Sarah Weiss is a professor of otolaryngology, head and neck surgery at Emory University in Atlanta, Georgia. She's the Emory Otolaryngology Residency Program Director, Rhinology Fellowship Director, and Director of Otolaryngeal Allergy. Dr. Weiss has served on the board of directors of the American Rhinologic Society and the American Academy of Otolaryngologic Allergy. In 2022, she became the first female president of the American Rhinologic Society. She was the lead author of the International Consensus Statement on Allergy and Rhinology, on allergic rhinitis, which was published in 2018 and soon to be updated. Her clinical interests include inflammatory rhinology, otolaryngeal allergy, relationship of allergy and chronic rhinosinusitis, and CSF leaks. Without further ado, Professor Sarah Weiss.
Thank you so much, Dr. Solovitsky, Dr. Zafario, Dr. Yaremchuk, Dr. Denani, and Dr. Alvarado. It is my true honor to moderate this panel today on endoscopic sinus surgery, technique and strategy to optimize patient outcomes. We have 5 speakers from around the world who are leaders in this area, and we look forward to hearing about their individual topics and then sharing some questions with them, questions which we invite you, our listeners, to write in on the Q&A function of our Zoom webinar. We'll get to the questions at the end, but first I'll introduce our speakers and we'll hear their individual talks, each of which will last about 8 to 10 minutes, so that we'll have somewhere around 20 minutes or so for questions at the end. You can see here the topics that we're going to address today. First will be 3 strategies for maximizing primary sinus surgery outcomes by Dr. Luis Fernando Macias-Valle. Dr. Macias-Valle works in Mexico City as a staff rhinologist and skull-base surgeon for the Spanish hospital. He's an assistant professor of otolaryngology, head and neck surgery for LaSalle University. His research interests include novel treatments for inflammatory sinonasal pathology, training models in endoscopic sinus surgery, and integration of multidisciplinary skull-base teams. Our next speaker will be Dr. Roy Casiano, who will speak about when is extended FESS indicated in primary sinus surgery. Dr. Casiano is an internationally recognized expert in the field of rhinology and endoscopic skull-base surgery. His area of expertise is in advanced rhinologic endoscopic surgical techniques and the management of complex sinonasal neoplasms. He currently serves as a tenured professor and vice chairman of clinical affairs at the University of Miami Department of Otolaryngology and directs the department's advanced rhinology and endoscopic skull-base fellowship program. Dr. Casiano has served as the past president of the American Rhinologic Society, as well as the Secretary General, Treasurer, and past president of the Pan American Association of Otolaryngology, Head and Neck Surgery. Following Dr. Casiano, we'll have Dr. Stacey Gray speak on tips for the revision sinus surgeon. Dr. Gray is an otolaryngologist with fellowship training in rhinology and endoscopic sinonasal and skull-base surgery. Her clinical interests include diseases of the nose and sinuses and endoscopic approaches to the skull base. She currently serves as an associate professor of otolaryngology, head and neck surgery, vice chair of otolaryngology education, and residency program director at Harvard Medical School. Additionally, Dr. Gray is the Sinus Center Director and at Massachusetts Eye and Ear Infirmary. Following Dr. Gray, we'll have Associate Professor Raewyn Campbell speak on pediatric sinonasal surgery. Is it safe, and what should we be doing differently? Dr. Campbell is a rhinologist and endoscopic skull-base surgeon. She serves as Associate Professor at Macquarie University in Sydney, Australia. She's actively involved in teaching medical students and otolaryngology trainees and teaches rhinology and skull-base courses in Australia and internationally. She's on the editorial boards for the Australian Journal of Otolaryngology and Rhinology and is a reviewer for multiple academic journals. Finally, to close our session, we'll have a case study presented by Dr. Pavol Surda. Dr. Surda is a consultant ENT and rhinology surgeon based at Guy's and St. Thomas Hospitals and London Bridge Hospital in the United Kingdom. He specializes in the management of sleep disordered breathing, nasal deformities, advanced sinus surgery, and skull-based surgery. Dr. Surda is a co-author of Surge Tech, offering crowdsourced surgical training videos, and is a regular faculty member in various instructional courses. He sits on the executive board of the European Rhinologic Society. So as you can see, we have an extraordinary panel of experts today, and we'll hear some interesting topics in the realm of endoscopic sinus surgery. And with that, I'm going to go ahead and turn things over to Dr. Macias-Valle for our first short session.
Thank you very much, Dr. Weiss, and again, a major thanks to the International Affairs Board, the American Academy of Otolaryngology, for the opportunity to participate in this panel. So what we're gonna be talking about first today is 3 strategies for maximizing primary sinus surgery. I kind of thought when we spoke about the topics that we're going to talk on today, that the topic that I was tackling sort of had the feel of a book that you can find in the aisle of the self-improvement section of your favorite bookstore. And I think there's something to it, and it's important just to identify that there are certain things that we can definitely start doing in order to improve ourselves and to be able to improve the outcomes that we give our patients. And this comes in a way of having this kind of participation in forums and the chance of having a continuous medical education. And with the pandemic in this type of international and virtual form that reaches over 120 countries around the world. Although it seems like it's a very complex thought, the reality is that most of the times we figure, or we need to understand that we don't need to do larger or to undertake larger strategies to improve our outcomes in terms of our patients. So in general, just be able to or to institute small but consistent changes and strategies will allow us to improve our outcomes and to have what we have here on the screen exemplified as what we call geometric growth, which means with a very small type of change to be able to tackle a much more complex thing like having improved results with our patients doing primary sinus surgery. So these are my disclosures. And why is it important, and why do we have to start speaking about this topic? We know from the available literature that our revision rate over the course of 20 years is over 15%. And after we've done a primary surgery, when we go into that spiral of revision surgeries, the timing between surgeries and the duration of improvement between those surgeries reduced dramatically between the first revision surgery and the 4th and 5th revision surgery. So we know that if we want to try to have a significant impact on our patients' quality of life, is that most of the time we have to do it right the first time. Most times we won't have a second chance to get that right. So the 3 strategies that I thought on, and this is obviously a tall task in terms of trying to simplify something as complex as the type of surgery that we do for patients in only 3 strategies. But I try to simplify it as much in order for everyone watching to implement some of these changes in their day-to-day starting next week on Monday. So I'm going to talk about 3 distinctive interventions in 3 different aspects of the timeline of the way that we see patients with sinus disease. First, the preoperative stage, which is essentially the planning, then the operational surgical part of it, and then the postoperative care that we need to give our patients. So the pre-op strategy that I came up with might seem a little bit vague, but it's very important. So first and foremost is to keep up with our knowledge. So keep up with all of the information that is compiled in different high-yield information documents, just like the EPOS 2020 guide and the ICAR guide from 2021. And this allows us to have a better understanding of the disease that we're tackling. Having a better understanding of the disease will allow us to have better diagnosis and ultimately to take better decisions in which way we need to treat our patients. So this is from the EPOS 2020 guide, and this distribution, I think it's pretty simplified and it's a friendly version of something that seems a lot more complex and difficult. So essentially having that primary or secondary CRS, and then the anatomical distribution between localized and diffuse, and then the endotype dominance in those types of CRS, and then eventually with the examples of the phenotypes that we all are used to, from allergic fungal sinusitis to eosinophilic CRS to local pathology like an odontogenic sinusitis or a fungal bowl. So once we have a better understanding and we're able to classify our disease a little bit better and have an adequate diagnosis, this will have an impact on what we have in terms of timing of surgery for a patient, the surgical planning that we do for them, the extent of surgery, and the post-op treatment. So this, just like the blueprints of construction, is the foundation of most of the decisions that we're going to take down the line. So although it is a bit of work, it is definitely something that will have a positive impact in the way that we're treating our patients. Now, in terms of surgical strategy, everything is based on the previous strategy, which is planning. And there's several aspects of it that are important that I think are also applicable for every type of disease that or every type of surgery that we do for different type of diseases. So in general, we aim to minimize collateral damage, so be mindful of the instrumentation of the inside of the nose, to have a meticulous dissection of the areas that we're working in. And this resonates particularly in some of the literature that I used as an example previously, where we know that the revision rate is different or differs from sinus to sinus, going from 12.4% for frontal sinus revision surgery to 5.4% for maxillary sinus revision surgery. Also, the extent of surgery is something that we need to keep in mind, and being able to have a better understanding of the disease and to be able to preemptively plan this will have an impact on our patients. So just a brief example of two cases that share certain similarities. In case A and case B, we can see a unilateral pattern of disease. We can see double densities, but obviously for everyone watching, you can always, or you can already assume that the completely different presentation from a case to case. So in the first case, we have fungal vole of the sphenoid sinus, and obviously by identifying this preoperatively, we know that the type of surgery that this patient requires to get a complete resolution of their symptoms is going to be a more specific approach just to the sphenoid sinus, being careful and systematic about the dissection and not needing a wider approach or something that is a little bit more extensive in order to solve their problems. Again, this will require the surgery only and probably not any type of post-operative medication, as based on the most recent information from all of the documents that I mentioned afterwards. So just for the sake of time, being able to solve this is a completely different thing from the second scenario that we showed, or that I showed, sorry, previously, where we see this unilateral pattern and with an intra-op aspect of what we identify clearly as allergic fungal sinusitis. And in this case, in this patient, we know that the extent of surgery is going to be or needs to be completely different, that meticulous dissection and being very thorough with the removal of all of the partitions to do an adequate dissection of the skull base, the ethmoid partitions, an adequate frontal sinusotomy, and plus minus an extended antrostomies will have an impact on the development of the disease of this patient. And to finalize the post-operative strategies, I think speaking for pretty much everyone, this picture is a true example of how we approach different days in our clinics. And when it's a clinic day, we're not that excited, and when we get to go to the ER and to do what we like the most, it's probably a better day of the week. But the reality is that what we do in clinic has a definite short, middle, and long-term impact on our patients. And this includes debridement, the prescription of irrigations, topical steroids. And what we have in terms of evidence from the literature is there is supporting evidence for the ICAR guideline to make a recommendation for normal saline irrigations in a grade B recommendation. The use of topical steroids with this type of irrigations is a grade A, and something that might be a little bit controversial. And if I ask the different members of the panel, we might have different views, is there is evidence for in-office debridement after the procedure, and the grade of recommendation from the ICAR guideline is a grade B. I would like to almost finish just by pointing out that there are different advantages from the post-op care, but it's nicely synthesized in this, what I call the 3 I's of post-op care, which is to identify signs of poor healing, to be able to intervene early, because if we don't bring our patients into the clinic to see them, we're not going to be able to take care of any problematic situations like the video that you just saw with a lack of integration of the natural ostium of the maxillary sinus into the antrostomy. And definitely, and finally, we need to invest time in what we did in surgery in order to allow our patients to have the best result possible with that primary surgery. So small but consistent changes and strategies, continuous improvement, and having up-to-date information will ultimately build up into better outcomes for our patients. This is all on my behalf. Thank you very much.
Thank you so much for your excellent presentation. I think that it's a difficult task to really distill down 3 distinct points that will improve your primary sinus surgery. I think an excellent point that you made is to really tailor our planning, our surgery, and our postoperative care to the patient's disease process individually, to their subtype or endotype. And I think we're learning more and more about that as recent evidence comes out. So thank you once again. And next, we will move on to Dr. Casiano, who will discuss with us about extended endoscopic sinus surgery in the primary case. So.
Okay, thank you, Dr. Weiss, and all the other panelists for spending some time reviewing the subject. So as far as extended sinusotomies, especially in primary sinus surgery, that's an area that's a little bit more controversial, becoming less controversial every day. I'm going to cover what in 8 to 10 minutes, what we do know. These are my disclosures. So when do we consider an extended sinusotomy just in general? And you heard a little bit from Louisa's comments about the importance of long-term surveillance of the mucosal inflammation, topical medical management, be able to facilitate approaches into these sinuses. That's another indication. Sometimes they have abnormal air cells that we need to really do much more exposure to get to be able to remove disease. And of course, the management of complications of not just chronic sinusitis, but acute sinusitis, such as abscesses, mucoceles, and CSF leaks. As far as primary sinusotomies specifically, there are some level 4 type publications that, although anecdotally we know and have been doing extended sinusotomies in primary cases for a long time. It is geographically based on where you live. There's obviously certain areas of the world have more problems with certain severe forms of polyposis like ARD. Certainly for kids or adults with cystic fibrosis, you want these wide cavities. I think the tendency is to create wide, full fesses. And of course, ciliary dyskinesia, because what you want to do in these cases is wide openings so that you can manage them medically long-term. There is documentation and publications suggesting that that when you have obvious osteogenesis, particularly the frontal, which is the narrowest one, that's another indication. And any combination of these factors, including asthma and very high Lund-Mackay scores, are warrant perhaps a primary extended sinusotomy. Additional indications include those of us that do oncology and do wide skull-based tumor resection. Where the extended sinusotomies are a fundamental skill set that needs to be gained in order to be able to resect these tumors, whether it's an extended frontal, extended sphenoid, or extended maxillary. People with fractures, when I was a resident, we used to do bicoronal incisions and obliterations for the frontal when people had fractures. Nowadays, we just follow them with CT scans, and if they do develop problems in the frontal, we would do endoscopic approach, extended approaches, so we can get in there. So the role of surgery, and again, Louise mentioned that, it's not how pretty everything looks, it's about how functional everything is. And you want to be able to take a patient who has chronic disease to be able to get wide cavities so that you can really manage them medically long-term. And the type of extended sinusotomies you see may include anything from extended maxillaries with or without preservation of the inferior turbinates, to different versions of extended frontal sinusotomy from a draft 2 to 2B to a draft 3 or modifications of that, or even sphenoid sinusotomies. As far as the Lothrop procedure, or a draft 2-3 or draft 3, there are primary indications for it. And again, it may be more geographically determined where you are as to the kind of disease you have. But I think we all agree that in patients who have severe osteogenesis, as you see here, it's going to be tough to keep this open long-term or be able to get medications in there. So these are one of the types of cases you might want to consider a primary Lothrop. Or cases like this, where you need to get wide exposure from one side to the other to be able to get that medial wall of that mucocele and get a nice big wide opening. In a puffy tumor in old days, those of us that have gray hairs, remember doing obliterations. Nowadays, just doing a Lothrop procedure and making sure you open up that abscess widely is really what's most important, and patients respond quite well to this. There are certain indications, as in this case, with patients who have bilateral grave decompression, and you can see the patients develop mucoceles in the area corresponding to the supra-agar area. And in these cases, you confirm it with an MRI, and really all you have to do is, in this case, we went transeptal. Our Aussie friends call this an outside-in technique, but we went transeptally. You can see the middle turbinate, we're anterior to it, and just to open up this patient's frontal in that area on both sides, and do a Lothrop procedure through a transeptal approach or outside-in approach. So in the case of maxillary extended, as you can see, you can do different versions and modifications, and the whole purpose, again, like the frontal, is to really get access to the floor of the sinus, or the lateral wall in this case, by removing the rest of the medial wall of the maxillary sinus. either with preservation of the inferior turbinate or just removing the middle thirds, as you see a mega, and you've heard the term mega enterostomy. And of course, there's a more of a medial maxillectomy with not preserving the lacrimal. You see the lacrimal here, or a mega enterostomy. This is actually a revision case, but you can see a big polyps originating from the maxillary sinus. And really, these are cases that even in a primary case, you might want to consider as a typical presentation of the antrochoanal polyp. A lot of these arise from the medial wall or inferior wall of maxillary, and it's good to be able to remove these things in its entirety by removing its origin in the maxillary sinus. And then you can see here in the case of inverted papillomas and tumors that we want to make sure we get a nice wide access to these cavities, not just the maxillary, but sometimes you'll have to go to the frontal sinus as well, so that you can widely expose the tumor, whether benign or malignant, and get an adequate removal with good margins. When some of these papillomas or disease extends anteriorly to the maxillary, in these cases, we would convert to a what we call dankers, endoscopic dankers. As you can see here, we're just taking the piriform aperture right in this area, and with a kerrison, we remove a segment so that we're able then to follow the anterior wall of the maxillary all the way forward and be able to actually identify the infraorbital nerve and remove the tumor or disease from around the infraorbital nerve. About that, or you can see the infraorbital nerve right below the suction tip. And as far as the sphenoid, Dr. Macias already mentioned, as in this case, this is a post-op video, but you get patients likewise with osteogenesis on one side, and sometimes it's safer to enter from the normal side to the abnormal side, crossing over when you're having a lot of osteogenesis and you're trying to set a probe to define the sphenoid that's not readily available. It's easier to go from the contralateral side. So that's another indication for a extended procedure. Or when you get these mucoceles in any of the sinuses, by nature, the disease is already asking you to create an extended sinusotomy. So these are all considerations. And of course, you want to have wide sinusitis so you can manage them appropriately. And then lastly, you can see that the extended sinusotomies can also be, in the case of the sphenoid, lateral extensions, as we do these lateral extensions through the pterygoid bone. So we get access to these meningoceles in the lateral recess of the sphenoid and be able to repair them. And then this is kind of the ultimate for extended sinusotomies when we do oncologic resections of the skull base. And obviously you have to have the skills to do the extended sphenoid, extended frontal, and of course, extended maxillary, many all in once at times. Thank you.
Thank you so much, Dr. Casiano. I think those were outstanding examples of when to consider some of our extended approaches. I'd like to also say I'm absolutely struck by how many of our international colleagues from all over the world are on today. And thank you once again for coming and joining us. We're going to move on to our third session, our third talk with Dr. Gray, who's going to talk a bit about revision endoscopic sinus surgery.
Good morning, and thank you so much for having me. It's really an honor to be part of such an esteemed panel. And I love when I'm going sort of not at the beginning, because I always realize how so much of what we say echoes the other speakers. So I'm going to focus on revision endoscopic sinus surgery. I don't have any disclosures for this talk. And I think all of us as sinus surgeons know that there are many times that our surgical procedure really improves our patient's symptoms, our patient's lives. And even though a CAT scan obviously doesn't represent everything as far as our patients are concerned, you can clearly see that this patient is probably feeling better. On the other hand, there are times that there are procedures that we do surgically, and unfortunately, patients get worse. And this is a patient who had a balloon sinuplasty and ended up having more extensive maxillary disease afterwards because the natural ostium wasn't dilated. So we know that, as sort of was mentioned in the first talk, that we do unfortunately perform revision endoscopic sinus surgery a fair amount. And we know that there are certain subtypes of patients with CRS that are more likely to recur, patients who have AERD, AFRS. And so the way that we approach things might be different for those patients. As Dr. Casiano mentioned, we might consider doing more extensive surgery up front. We know that over time, the revision rates of surgery actually are decreasing, which I think is related to understanding better postoperative medical therapy and also better techniques. So a lot of this is mainly thinking about ways to avoid revision surgery if possible. So there are a lot of reasons that patients fail after endoscopic sinus surgery. And for some, it might be something as simple as inadequate postoperative medical therapy. As has already been mentioned, the postoperative care for these patients is extremely important. Some patients just have recalcitrant disease, like this patient who has recurrence of polyps in the frontal recess. And there are certain cases where patients are more severe. As has already been mentioned, patients with secondary chronic rhinosinusitis, so not traditional primary CRS, have a different disease process, and that needs to be addressed differently. On the other hand, there are times that there's an error in surgical technique, which ends up resulting in failure for our patients, like this patient who clearly has scarring and neoosteogenesis and that has obstructed the frontal. So in order to determine what is causing the failure, we have to really look into why this is actually happening. And part of that is actually doing repeat imaging a lot of times. So for patients who are not improving, it really is important not just to rely on endoscopic examinations, because sometimes you will miss issues that have recurred. And certainly I think there's nothing more humbling than seeing a postoperative scan of one of the patients that you've operated on and realizing that what you were attempting to accomplish has not been fully accomplished. And again, thinking about whether the issue is related to disease recurrence or if there's something else going on, if there's scarring from prior surgery, maxillary sinus recirculation, or if there's actually just been insufficient surgery. So maybe someone who should have had more extensive surgery at the beginning. So the principles of revision surgery are really the same as primary surgery. You really should be tailoring the surgical plan to the disease process itself. However, it's much more important to consider really trying to create wider surgical openings, especially if the patient has issues with scarring or significant disease, because what we're intending to do is really improve postoperative medical therapy after surgery for many of these patients. Unfortunately, in revision cases, we know that there's an increased risk of potential complications, and that is because the patient's anatomy is distorted and there's more severe disease. So it's even more important in these cases to really make sure that all of the equipment that you're using is really something that is going to be able to adequately handle this. And that includes things like image guidance. However, the steps for surgery really should be the same. You want to follow the same procedure every time. So thinking about maxillary antrostomy, there are a lot of things specifically that you want to make sure are not an issue. And one of the most important is really ensuring that the natural ostium has been incorporated into the maxillary antrostomy. However, there are also times that there's an inadequate opening. And this is a good example of the maxillary ethmoid plate sort of for these cases often being a problem. And an easy way to include and really increase the size of that antrostomy is to widen that posteriorly. Maxillary recirculation is something that I see very frequently, and it's such a simple thing to avoid for the first case, and also such a simple thing to revise fairly simply. Looking at the CAT scan can really be very helpful in these cases to really identify the location and really the sort of the way that where the position of the actual natural ostium is located. Using an angled scope in this situation is extremely helpful. That's one of the reasons I always use an angled scope when I'm just doing a standard maxillary antrostomy to try to decrease the risk of missing that natural ostium. And this is a really simple thing, but something that often results in significant issues for our patient. dividing that one single small little band of tissue really can improve quality for our patients. Dr. Casiano also already mentioned this, but considering modified neomaxillectomy or a megaantrostomy, especially for cases where you know the aperture for that sinus is going to be very small, or if the disease process itself, like cystic fibrosis or immune dysfunction or issues with ciliary dyskinesia are an issue, because we know that this procedure allows for better access for topical irrigations. Revision ethmoidectomy, I think, is something that we see a problem with very frequently. And one of the issues that really need to think about is the middle turbinate and whether it itself is diseased. Oftentimes in primary surgery, we like to leave that middle turbinate alone. If it's the major issue, whether it's scarred or whether it's actually forming a massive polyp, then thinking about resecting it is something that we know can be very helpful and also does not really create significant problems in the future. The biggest issue is making sure that you don't obstruct the frontal. So if this is a case where the middle turbinates have been previously resected, but because the polyps recur sort of in the septal region, they push the middle turbinate remnants laterally and end up obstructing the frontal. And in this case, there's also scarring as well. So as you're resecting the middle turbinate, you need to really plan exactly how much middle turbinate to resect. Sphenoidotomy, revision sphenoidotomy, Dr. Casiano already mentioned this as well. In this case, you can see the significant hyperostotic bone and scarring that has occurred. And so thinking about doing a bilateral sphenoidotomy, posterior septectomy, and even removing some of the sphenoid floor can really be helpful for these patients as well. To really create the widest possible opening into the sphenoid cavity. Revision frontal sinus surgery, I think, is like a whole lecture in and of itself, unfortunately, but really sort of thinking again about whether or not a larger opening is necessary. So in this case, for someone who's had surgery before and has unfortunately developed an abscess in addition to their polyp disease, you could think about simply doing a draft 2B in this case, or obviously more extensive surgery like endoscopic modified Lothrop. Again, to highlight the fact, the necessity of really having appropriate equipment, especially when you're doing complex revision cases, is extremely important. Being comfortable using angled scoped, angled instruments, curved drills, as well as being comfortable using image guidance, I think really help to improve the success of these cases. The Agranasi punch-out procedure, I just wanted to mention really quickly, sort of removing the face of the Agranasi really can be very helpful, especially for cases where you're really trying to view the frontal sinus. It also helps though after the surgery because you widen that space. Even if the bottom of the middle turbinate lateralizes a little bit, you'll still have a nice opening to be able to monitor the frontal cavity. And obviously, for cases like this, where there's significant frontal disease, these patients are ultimately going to require draft 3 or endoscopic modified Lothrop to be able to create a wide enough cavity postoperatively for these patients to continue to have good medical care. The other thing is that in these cases, immediate postoperative management is going to be very important. You want to really think about strategies to decrease adhesion formation, and that can be different for your practice. But certainly, as has already been mentioned, thinking about middle meatal packing, even stenting in some of these cases for some of the extended frontal surgery, but really highlighting the importance of irrigations and debridement, as well as perioperative medical therapy to decrease the risk of scarring right after the surgery. And again, I think most importantly, postoperative medical care, especially for our standard CRS patients, is absolutely crucial. Recognition that patients often have multiple diseases, whether it's allergy, whether it's asthma, that are potentially impacting their symptoms and need to be addressed separately so that patients ultimately feel better after they've had surgical intervention. So in conclusion, it's really important to assess the reason for failure, understand that before thinking about doing a revision surgery, tailoring the surgery to the disease itself, and then really how important optimizing your visualization and instrumentation for these complicated revision cases is key. And really then afterwards, long-term medical therapy is necessary to really provide sustained improved outcomes for our patients. And with that, I will conclude.
Thank you so much, Dr. Gray. I think, we all face revision cases, and kind of thinking about these systematically is incredibly helpful. for our patients, and hopefully we'll keep them out of the operating room or surgical theater in the future. So next we will move on to Associate Professor Raewyn Campbell, who is joining us from Australia. So it is very early in the morning, and we are honored to have Professor Campbell with us today. And she'll be talking about pediatric sinonasal surgery.
Good morning, and thank you very much for the invitation. It is an honor to be here amongst this esteemed panel. So I'm going to change tack a little bit and talk about operating on children in sinonasal surgery. So nasal obstruction is incredibly common, but a lot of our children are actually suffering from nasal obstruction. And a lot of these children who, 79% of mouth-breathing children report that they've got a blocked nose. The most common cause of this is allergic rhinitis, and the prevalence of this is increasing. And a lot of Australian children, at least, or anyone with allergic rhinitis here, will often rate our symptoms as moderate or severe. Now, if we look at CRS, it actually originally thought that this is not very common in children. That's actually not true. The incidence of CRS in children can be even higher than that in adults. Now, in adults, the most common symptoms of CRS are things like hyposmia, nausea, postnasal drip, etc. But in children, they're more likely to have a cough than they will hyposmia, and it's more likely to be a productive cough, nocturnal, and it can be followed by vomiting. And rhinorrhea is also one of the more common symptoms in children. Now, if we look at the difference between pediatric and adult sphenoid sinus disease, sphenoid sinus disease doesn't really become clinically relevant until sort of the age of 10-ish. And fungal etiology is actually incredibly rare in the pediatric population with isolated sphenoid fungal sinus disease, yet the incidence of neoplastic processes causing this between adults and children is actually very similar. Also, in children with CRS, they're more likely to have an allergic history and allergic family history, and they're more likely to have sort of a neutrophilic disease as opposed to, as we all know, in adults. Also, children's microbiome is different, and it's a lot less diverse than in adults. So is nasal obstruction a problem in children? Well, we all know that at rest, we actually use our nose predominantly to breathe. It's actually really important for the upper airway tone, especially during sleep, and for craniofacial development. Upper airway resistance is actually a lot higher when you use your mouth to breathe than with nose breathing. Now, if we look at the impact of this on respiratory musculature, mouth-breathing children actually have weaker respiratory muscles and reduced pulmonary function values compared to nose-breathing children, and this often improves after an anotonsillectomy. Also, there's a huge impact on quality of life in children with blocked noses, including impaired psychometric development, as well as cognitive and psychomotor performance. Also, if we identify allergic rhinitis early and treat it, we can actually prevent the onset or reduce the severity of asthma. So let's take a little bit of a look at the difference between the upper airway in children and adults. I love this quote. Adults have more face and less brains, and children have more brains and less face. And this is actually really true. So with adults, they can demonstrate sleep disordered breathing despite having a patent nasal airway. And that's because they've reached craniofacial maturation. But children can demonstrate sleep disordered breathing due to an obstructed nasal airway. And that's because craniofacially, they're not as mature. And I'll go on to explain that. So if we look at the upper airway between children and adults, adults have a greater nasomaxillary height. Also, this angle here is greater in adults. If you look at where the hyoid is in children, it's sort of tucked up underneath the tongue, whereas in adult, the hyoid bone has descended into the neck. The pharynx in an adult is longer, and they've got a greater tongue height compared to children. And also the pharynx is more obliquely located in children compared to adults. So the mechanical arrangement of the tongue and velopharynx in an adult, this is unstable. And so they could get obstructive sleep apnea independent of whether their nose is blocked or not. And so unblocking a nose in an adult who snores is not going to cure their snoring. But in children, this arrangement is actually stable. So they've got much greater airway stability at the level of the tongue. And when you get a mouth breathing child to revert to nose breathing with their mouth closed, you can actually resolve any form of sleep disorder breathing. So it's really important that we aim for nasal patency in our children, particularly those that have sleep disordered breathing. So the absence of nasal airflow actually does impact the growth of a facial skeleton. We all know that. You need this continuous nasal airflow as a stimulus for lateral growth of the maxilla and for lowering the palatal vault. Also, a blocked nose will alter orofacial muscle activity. So a few things sort of on the pediatric development of the sinuses and the nose. So you can see here that the age at which maximum growth velocity is reached is a little bit different between girls and boys. Girls, it's around 11, and boys, it's a little bit later at 14. If we look at the septum, this is a midline structure, but it has lots of bones and one cartilage. Each of these have their own ossification centers, sometimes multiple, and it's encased by the other facial bones and structures. So it's a structure that can be impacted by its surrounding structures, but also can impact these surrounding structures on its own. Now, it is purely cartilaginous at birth and it progressively ossifies, but the growth of the septum will plateau at around the age of 20, and it does continue to grow up until around the age of 36. Now, the cartilaginous dimensions are reached at 2. So any growth after that is usually mostly due to the perpendicular plate, which continues to ossify. And that's because the voma ossifies a lot sooner than the perpendicular plate. But a lot of babies are born with a bent septum. They also fracture their septums more easily because they're cartilaginous and they can get green stick fractures. And it depends on what age they get that fracture, the location and the severity of the damage, as to whether this leads to any long-term impacts, especially if it occurs before the age of 3. Now, with the septum, the junction of the perpendicular plate of the ethmoid and the cartilaginous septum, this is actually a key growth zone for the nose, whereas the junction of the septum and the voma is not a key growth zone for the nose. Now, the dorsal septal cartilage is one of the main supporting structures of the nose, and it's a facial growth center. So you can get quite significant impact, particularly with the growth of the orbit, nose, and maxilla, if there is any injury or loss to the cartilage in this particular area. And this is a study looking at children with deviated septums versus those who didn't. And you can see just with a deviated septum, it leads to quite a few craniofacial abnormalities compared to children who had a reasonably straight septum. This is a longer-term study looking at the impact of septal deviation of facial growth, showing that those who did have a deviated septum do have quite significant facial asymmetry. And here's another study showing the impact of this more severe the septal deviation correlated with the more nasal asymmetry as well as palatal asymmetry. Interestingly, the incidence of asthma is a lot higher in people with deviated septums, and that incidence improves after septoplasty. And if you look at this child who'd had a deviated septum and then you follow his facial growth for 9 years later, you can see how that has impacted his facial growth. So how do we avoid these significant asymmetries and achieve facial symmetry in our children? So is it safe to operate on children's noses, or are we being too conservative? So this is a study looking at pediatric septoplasty and following them up for quite some time after the surgery. And you can see the mean follow-up was over 12 years. And there was essentially not a great difference in facial symmetry with those that had a septoplasty and those who hadn't. And this has gone on with further studies essentially to show the same thing, that there weren't a lot of craniofacial abnormalities, in fact, none, in children who underwent septoplasty. Now, when we do consider doing septoplasty in children, we do need to consider some key growth zones. There's the sphenodorsal zone and the sphenospinal zone. Now, these growth zones, this sphenodorsal zone contributes to the development of the length and the height of the nasal dorsum, whereas the sphenospinal zone is responsible for forward projection of the premaxilla and the maxilla, and also sagittal growth of the septum. These are key zones we need to be careful of when we are doing septal surgery in children. There's also the septospinal ligament, which attaches the septum to the premaxilla, and that contributes to outgrowth of the dorsum of the nose. So when we are doing a septoplasty, it's important to leave the mucopericondium intact, but it's safe to elevate it. We also need to reconstitute areas of contact between the septum, the voma, and the perpendicular plate, particularly that perpendicular plate, and reposition and remodel any cartilage. But do avoid dividing that septospinal ligament and also separating that cartilage from the perpendicular plate dorsally, as I mentioned earlier, as these are key growth zones. So what about the inferior turbinate? The inferior turbinate embryologically develops very differently to the other turbinates. It actually develops on the lateral nasal wall compared to the middle turbinate and the superior turbinate, which develop on the roof and the septal wall. The inferior turbinate actually develops from the maxilla and the lateral cartilaginous capsule, whereas the middle turbinate and superior turbinate actually develop from the ethmoid bone. Interestingly, the inferior turbinate has its own ossification center. Now, the inferior turbinate is already ossified by the time a child is born. So inferior turbinate surgery can't affect the development of any other facial bones. Yet a blocked nose due to a large inferior turbinate will. These are studies looking at where they actually did turbinectomies in children with quite extensive follow-up, up to 14 years. No impact on facial growth and no evidence of atrophic rhinitis. Also, if you look at sinus surgery, again, when they looked at people who'd had sinus surgery as children versus those who didn't in their adulthood, there was actually no impact on their craniofacial growth from having had that sinus surgery. Pediatric sinus surgery is safe and it doesn't compromise facial growth. In fact, children with chronic rhinosinusitis undergoing sinus surgery actually do better than children managed continuously on maximal medical therapy, and it's very successful. So in summary, chronic nasal obstruction will impact facial growth, but pediatric sinonasal surgery does not, as long as it is done with some key considerations. Pediatric nasal obstruction should be treated. And we ideally want to achieve airway patency before the age of 6 to have the greatest impact on their craniofacial growth. So this is a child, just to finish, who you may not be able to hear it, but had quite significant sleep disordered breathing. I'm going to move forward to show her CT scan. And as you can see, she actually had pan sinus disease. And sorry, I'll just go back. I actually did do surgery on her. She actually did have a septoplasty. This is just showing the significant sinonasal disease bulging out that medial wall. But she underwent a septoplasty. This was my incision on her because it was quite deviated. And also I did endoscopic sinus surgery, and this is her a week post-operatively. So thank you very much.
Thank you so much, Associate Professor Campbell. These talks have been extraordinary. We're having lots of comments in the chat about the quality and the fact that everyone's learning some fantastic things from what's been presented thus far. I will note that we've had our panelists answering many of the questions in the Q&A, and we'll address some of the common themes verbally here after Dr. Surda's final presentation. So with that, I will turn things over to Dr. Pavol Surda, who's going to go through a case with us. I think you may be on mute.
It should be fine now. I thank you so much for inviting me. It's a really pleasure and honor to be here. Thank you, Sarah, for working hard to putting together such a fantastic panel of speakers. And I will start with a case presentation, which I found slightly challenging, but also because of different possibilities and trying to really find my head around. So this is a case of a 42 years old gentleman who presented with 1 month history of nasal congestion, crusting, pure nasal discharge, diminished olfaction, intermittent nosebleeds, intermittent swelling of his right eye only recently, and persistent facial pain, which has been there for a much longer time. Now, the confounding factors, or for me, were the previous history of chronic rhinosinusitis. We're talking about disease that was mainly treated 10 years ago with FESS, and the patient was under control for a longer time. And a recent onset of joint pain, weakness, and unfortunately, in London it's very common, history of occasional cocaine use. I think this needs a bit of a detective work. And in the first step, obviously, as you see the patient in the clinic, you can perform the nasal endoscopy. A nasal endoscopy showed very angry looking inside, difficult to orientate yourself, crusting, intact septum, and erythematous mucosa and scarring. And the imaging that I was able to organize on the day showed destructive process and a lot of inflammation. I'm going to go to that a little bit later. I'm going to just explain a little bit my brain or my process, thinking process. I always try to find or list down the differential diagnosis that can potentially answer the question what it is. And my main suspects were ground GPA, then 11-macil-induced rhinitis, cocaine overuse, malignant neoplasm, and other granulomatous conditions, especially EGPA, because that is associated with polyps and asthma and infectious conditions. Now, I'm going to break down the symptoms and why and which one would point to this particular type of diagnosis. So blockage, discharge, epistaxis, joint pain, weakness, lower respiratory symptoms, all of that will point towards GPA and other granulomatous conditions. History of cocaine use, obviously, hyposmia, pain, blockage, that would point towards the levamisole-induced rhinitis. Now, orbital symptoms and destructive changes on the CT scan, that would point towards the malignant neoplasm, and lower respiratory symptoms would point towards the tuberculosis, but I note that the patient had no history of travel or recent TB exposure. And in the next step, we need to organize the tests, which will encounter all those differential diagnoses. And in this particular case, we need imaging, obviously, that was done, laboratory investigations focusing mainly on the vasculitis, and then routine urine drug test that will focus on the cocaine, methamphetamines, and nasal mucosa biopsy. The CT scan showed, I'm going to come back to that because I think it's important, loss of structure, inflammatory changes in the frontal sinus, intact septum, at least at this moment, and then possibly early orbital invasion and infiltration process. And the following tests show the elevated CRP, positive C-ANCA, and the remaining findings, including the liver and kidney profile, were normal, and drug screen was negative. And the histology showed granulomatous infiltration, areas of necrosis, and predominantly neutrophilic infiltration. So now, given all these results together, the diagnosis obviously was GPA. Now, what I found, what were diagnostic challenges in this particular case? First of all, the EGPA. So we know that there is a strong association with asthma and polyps. So we always have to point this one out, and we would see in the histology, in the histological findings, the eosinophilic infiltration. Then the 11-macil-induced rhinitis, which is becoming a big problem, especially in London. We would see the key differences. The P-ANCA will be more likely positive than C-ANCA. Then if the PNK is positive, we can always organize the HNE, human neutrophil elastase, which is way more sensitive and specific for cocaine overuse. And then in GPA, it will be extremely rare to see them to see damage of the pellet, of the midline structures. But on the other hand, in a cocaine overuse, the midline structures are the ones which are mainly damaged. And obviously, we need to focus on the history taking. On this topic, we published one paper led by Professor Hopkins, where we included the patients who denied all use of cocaine, only those were included, and there were vasculitic changes on the examination, and all the patients where we knew what was the reason were again excluded. So we only had a group of patients where we had to find out. And out of these patients who denied use of cocaine, 37% of them had a positive test for cocaine. And important is that the test for cocaine, the urine test, would give you positive outcome only for 48 hours, which means those patients must have used it only recently. Therefore, it is really important to take this into account. And now, before I follow or before I link to the management, I would like to ask the panel. I think the main question in this particular situation is whether to perform the sinus surgery. And the reason for that is the facial pain and complete opacification of the frontal sinus, and the facial pain, which is progressively getting worse. Obviously, the patient needs to be optimized. The patient needs to be seen by the rheumatologist. The patient needs to have immunosuppressive medication. But if the pain continues, whether any one of the panelists would proceed with a surgery and under which circumstances?
I'm happy to jump in here, Pavol. So, I think that, as you mentioned, optimizing the situation, having good control of the underlying disease by, with help from our rheumatology colleagues is critical. But if the patient is, developing a mucocele and symptomatic from the disease, you certainly could, would consider operating on them in this situation. I think also taking as many steps as you can to maintain the patency of the outflow of the sinuses is incredibly important.
And would your choice, if the surgery needs to be done because conservative treatment fails, draft 3, or would you draft 2A, or directly jump to the draft 3, which means the frontal drill out, in order to avoid the possible stenosis, which which in the GPA is extremely high?
Yeah, I think you certainly could consider a more extended procedure in this case, and whether that's a full draft 3 or even a draft 2B or some extension over to the contralateral side. That's certainly reasonable to try and maintain the patency as much as possible.
So in our department, the practice is really to maximize firstly, of course, the medical treatment, and then I have a proper multidisciplinary workup with the rheumatologist. We were very keen on using xylitol cell induces as well to reduce the biofilms, and glycerin lubricants, which also work quite well. And rheumatologists, or together with rheumatologists, we often prescribe the cotrimoxazole because this has been identified as a very effective treatment against the Staphylococcus aureus colonization, which seemed to be the major factor for GPA relapses. And in terms of the surgical managements, we know that FESS has got very limited role because of scarring. Therefore, it should be the last option. But sometimes the osteogenesis, as we've seen on the CT scan, can completely close down the frontal sinus, which can result in the mucocele, which can result in further problems, and it might be needed. But obviously, the patient must be closely followed up by the rheumatologist. And the way how we can make sure that or understand that the disease under control is frequent monitoring of the C-ANCA, which can tell us whether the disease is under control or controlled or not. And when it comes to septal perforation, we are in this particular case, there wasn't one, but normally we do not proceed with the closure. We would perform prefer the septal button if needed. And usually the surgery that we tend to perform is a rhinoplasty if needed, but in this patient, it wasn't the case. So I think we answered these two questions. And in this particular case, we actually we're planning now the frontal sinus surgery. We're going to go for draft 3, so wide opening, and the patient will have preoperatively prednisolone for 14 days, and then also after the surgery to make sure that disease is under control. And there is also biological treatment, and we have to discuss this very carefully with the rheumatologist. And the last slide is that GPA stands for glomerulopathy for not with polyangiitis, not Gotha party always. And it's very important to take into keep in mind that there is this misuse of cocaine, which might make it worse. Thank you.
Thank you so much, Dr. Surda. That was a fantastic case, definitely very difficult and challenging patient situation. So we've brought all of our panelists back on the screen. And as I mentioned before, we've had a lot of fantastic questions in the Q&A, some in the chat, and many of them have been answered in writing by our panelists along the way. We have a few minutes left, and so I have kind of written down some themes that I saw frequently in the questions along the way. So I'd like to just kind of throw some of those out for our panelists to comment on. There were a handful of questions about the use of corticosteroid, topical corticosteroids postoperatively. How long do we use them? Choice of particular corticosteroids, things like that. So maybe we can just kind of comment on that theme in general. Perhaps I'll toss that one to Dr. Gray for some comments.
No problem. So as I mentioned, I do think that postoperative medical therapy is absolutely key for patients. And it's really important, as we have kind of mentioned a few times, to really understand the type of chronic rhinosinusitis that patients have before considering what postoperative therapy you're going to be choosing. So certainly for patients who have CRS with polyps, or sort of our typical eosinophilic type of patient, we know that they tend to do very well with postoperative steroid therapy. I usually try to have my patients, at least for the first 3 months after surgery, using some type of a topical steroid irrigation. I typically use budesonide because that's the easiest for our office to sort of have. We have a fairly well-developed approval process, either through insurance or through compounding pharmacies, to obtain that. And then I typically reassess patients at 3 months to see how their cavities are appearing. And then we have a discussion about long-term therapy after that. Many patients are able to also determine with their symptoms how they're doing and sort of modulate how much topical steroid they're actually using, and whether or not it's sufficient to use a spray, which is often less expensive than steroid irrigation.
Can I follow up on that? There were also questions on preoperative management with steroids. Does anybody uses steroids before surgery, and what's the rationale?
I have to admit I'm quite conservative preoperatively for a couple of reasons. One, if they've got severe enough disease, topical steroids may or may not be that effective, plus they're not cheap. Second of all, any systemic steroid, we do need to now be quite, just like antibiotic stewardship, we actually have to have corticosteroid stewardship as well. We now know that we need to be mindful of the lifetime dose of systemic corticosteroids we give our patients. Once we get above 4 short courses of systemic corticosteroids, that's when our patients are then in that risk zone for the long-term side effects such as avascular necrosis, sepsis, osteoporosis, etc. So the final reason is obviously it can impact any biopsies that you may do intraoperatively, which help really target my treatment postoperatively. So it's pretty rare that I will give any systemic steroid preoperatively. I will often do it postoperatively, but not preoperatively.
Yeah, I don't use routinely steroids for the same reason. Most of these patients already come to me that have failed steroids. Sometimes I'll use it, if anything, in the United States, because we're required to show and document that they've recently been on it again by the insurance companies. But that has nothing to do with patient care. And basically, if they fail, they've already needed surgery because they've failed before.
I think the only other thing for steroids perioperatively specifically is to consider if they have severe asthma. So one of the things that I do often consider, especially many of those patients will also be followed by a pulmonologist or an allergist. If I'm worried that their surgery is going to be canceled on the day of surgery because of the severity of their pulmonary disease, then that's a time that I would consider making sure they're optimized. And sometimes that means steroids. There is a lot of literature to suggest that perioperative steroids do help with sort of diminishing bleeding and sort of improved visualization. That was sort of how I was trained. And then because of a research study that required patients not to be on steroids perioperatively, just with my own experience, I realized most of the time it's actually probably doesn't make a dramatic difference as far as from a surgical standpoint.
Thank you. What about post-operative debridements and post-operative visit frequency? We had some questions come in about that. Any comments? Do people have a standard protocol for post-operative visits and post-operative debridements, or is that individualized based on the patient? Love to hear some comments about that.
So I'll be happy to answer that. I think it is a controversial topic, as I mentioned, despite the fact that there is certain evidence and guidelines for it. You do find studies in the literature that have found not a significant difference in repetitive postoperative debridements, but I think it is an individualized decision, and it depends on the type of surgery that you did and the type of disease that the patient has. So I in general, what I do is I do like to see them within the first month, at least 2 to 3 times, but that's just because the way that my healthcare system works, and this is something that varies from country to country. So I know that in places that it's difficult to get people in clinic just for that might be a little bit complicated. The fact of the matter is that if you're not able to see the patients, you're not able to intervene early and to make changes. So it doesn't necessarily mean that you're going to be debriding actively or aggressively all of these patients. But the reality is that to bring them into the office, to be able to look into the cavity, to see for signs of poor healing, for changes in topical medication, to do any type of intervention is beneficial. So for me, particularly within that first month, it does imply at least 2 visits.
There are a few questions on how do you prepare your budesonide irrigation, what dose, and how do you recommend the use?
So for my practice, we use if patients are able to have a prescription, which is typically used off-label, so you have to often get a prior authorization. It's either the 0.5 milligram per 2 cc Respule that's typically used for asthma in a nebulizer. There's also 0.25 milligram per 2 cc dosage as well. And then I have them mix that Respule with the 8 ounces of saline in a typical sort of the NeilMed application for an irrigation bottle. If we're not able to authorize that through their insurance, we typically use a compounding pharmacy, and the budesonide dosage for that is 0.6 milligrams that then add to the irrigation.
And does anybody uses mometasone?
I do.
Yes, I've transitioned to mometasone just because of what I have read from mostly asthma literature. The pharmacologic properties seem to be a bit better for mometasone. And so the dose of that is typically 1 to 2 milligrams of mometasone per 8 ounce or 240 cc rinse bottle. What about kind of the threshold for revision surgery? How long, in general, I realize there's some, obviously some individual considerations, but when you're considering revision surgery, how long would you potentially treat the patients with medical therapy versus encouraging them to, consider a revision surgery?
I think that really goes down to what you're having to manage them with, and also patient symptoms. I mean, you might see someone who looks terrible, but they feel great, or vice versa. And also if you're having to manage them with any systemic therapy, whether it be antibiotics or steroids or something like that, once you start having to do that more frequently, and the benefits of revision surgery far outweigh the benefits of ongoing medical therapy. Obviously, it's an individualized thing with patient fitness for surgery, but I think we do need to be really mindful of risk versus benefit. And the risk of surgery, relatively speaking, is quite low, whereas long-term medical therapy, there are quite a few risks long-term from that.
I think something that Dr. Campbell had mentioned before really is quantifying how many steroid tapers patients are requiring in a year. One of the ways that it's often a very personal discussion with patients, but what I often ask them is how well they feel their disease is controlled. And so that is sort of a big question just to ask as far as really getting a sense of where they're feeling they are on the spectrum. And even though there are times certainly where I see patients and their disease looks worse than they're feeling, especially if you're concerned that there's potentially a complication brewing, that would be another time to consider really trying to think about doing something surgically as a revision before they end up having an orbital complication.
We may have time for 1 or 2 more questions or discussions, but I would love to hear from the panelists if they typically use any kind of packing or stenting after routine sinus surgery. That sometimes is a controversial topic, but it kind of gets to management of the middle turbinate, preventing lateralization, and kind of care of the postoperative cavity in general. So Pavol, maybe we'll start with you.
Thank you. That's a really good question. Thank you. So first of all, I tend to make sure that I will never fracture middle turbinate. I will not fracture middle turbinate. And if I see at the end of the surgery that it's stable, doesn't move, there is no fracture, it's not floppy, then I would not use any stenting or nasal packing. And the patient will afterwards just have a standard post-operative treatment. Now, if I will feel that the middle turbinate has been fractured, it's floppy, it tends to lateralize, I would perform the stitch through the septum and through the other contralateral middle turbinate and stabilize it this way. And this works really well for me.
Great. Luis?
Yeah, I think I've transitioned from doing a lot of packing in early years after fellowship and stenting or using material there. And the reality is that most of the time we do have to keep in mind that anything that we leave behind will have an inflammatory impact in a cavity that we're trying to decrease that inflammatory load in. So I would say I've strayed away a little bit from using packing as a general rule. I would say to try to obviously or actively prevent any type of lateralization from the middle turbinate is important, but there's several ways to do that and not rely on packing. The other thing that, at least here in Mexico, we don't have is a medicated stents, which might be a good option in certain patients. So for that reason, it's something that we don't use regularly.
Any additional comments on packing or stenting from Raewyn, Roy, or Stacey?
I use some of the I kind of migrated to inexpensive, I guess you could call it, use of the chitosan products. They go by different trade names: Novapac, Posicep. There are a bunch of different chitosan there, and I infiltrate them. What I do is I make little like Otowick type. You can cut them to Otowicks, and I put one in the frontal outflow tract and one anteriorly, kind of around the axilla of the middle turbinate. And then I infiltrated with a combination of Kenalog and gentamicin with diluted in just water, and that turns into like a gel, and it holds it. It holds everything. It's impeccable when you take it out. Everything looks like there's hardly any edema in the cavities, and just suctions away because it turns into like a gel.
I don't use anything. Oh, sorry, Raewyn.
No, go for it.
No, I'm done.
I was just similar thing. I'm moving more and more away from anything. I've been more aggressive with managing the middle turbinate with a stitch, or even trimming the lower third of it to avoid any lateralization. And I still have been putting a silastic in the frontal, particularly if I've done a drill out or anything like that. I will still put some form of silastic, because as we know, the frontal sinus will continue to change for up to 2 years after any surgery. So that's the only other one caveat I have is a silastic.
Fantastic. So again, I'd like to thank all of our panelists, and an enormous thanks to the American Academy of Otolaryngology, Head and Neck Surgery, and the Pan American Society as well for co-hosting this. I'll turn things back over to Dr. Zaferio for some final comments.
Thank you so much, Drs. Wise and Stolovitsky, for such an excellent educational session. We had over 700 participants from across the globe, and I think you can tell by the dozens and maybe hundreds of comments in the chat the appreciation everybody has for your time today. And thanks to our panelists, Dr. Macias-Valle, Casiano, Gray, Campbell, and Surda. It's just been an excellent educational session. Thank you. We do have an upcoming Global Grand Rounds in March 25th. You will receive further information about this next week. New Frontiers in Pediatric Airway. This will be a special International Young Physicians edition. So we encourage especially all of our international young physicians to register and attend. We also have a laryngology global grand rounds planned for May 13th, 2023. So please put that on your calendar. And these are all 9 to 10:30 Eastern US time, and they're all free. You just need to register. We remind you about our annual meeting in Nashville, Tennessee, September 30th to October 4th, the Music City. If you enjoyed this educational webinar, there's much more of this at the annual meeting, and it can be live and in person. It's fun, it's educational, so we hope you can all register and join us in Nashville September 30th to October 4th. Registration is online. And if you'd like to become a member of the American Academy of Otolaryngology, Head and Neck Surgery, we have a lot of information about membership on our website. Just to remind you, there are special discounts for depending on which countries you live in. So all that information is available on the web. So with that, we thank you all. We thank again Dr. Wise and Stolovitsky, our moderators. Good morning, good evening from wherever you are in the world. Have a great afternoon.